Good morning. This is Dr. Mark Sehl from the YouTube channel Therapy for the Heart. It's nice to be here. It's Tuesday morning with Mark, and I think I missed 1 week here. So it is Tuesday, and this is the 41st video, I believe. I tried to play with the sun in the back here because if I make it too late in the morning, then the sun just really is right behind and bright, and I have to sometimes put cardboard, in the windows, so it's not so bright. But I'm not complaining. I like the sun. So today we're going to talk about dependency in the therapist-patient relationship. In the last talk, by the way, there is a podcast out too now. So it's a companion. It's not competing with. I hope you don't feel it that way, because it really adds to the accessibility that people can have. They don't have a PC sometimes, or they might want to listen to the podcast as they're driving or working or walking around the streets. So this similar content, just podcasts offer a lengthier talk. Many people don't want to watch videos if they're too long. As a matter of fact, they say the best time element in that is maybe, I don't know, 2.5 minutes. I don't know. So anyway, I'm going to do what I'm going to do. So that's podcast Therapy for the Heart. Yep. So look it up. Just put it in iTunes or put it in your podcast app. So we're going to talk about dependency, and I did a study of therapists and the incidence of erotic countertransference in social work practice, and this is not going to focus on erotic countertransference, but I thought about that study because some therapists had sexual relationships with their patients. Now, this is not widespread, but it does happen, and it shouldn't happen, but it does. And what struck me was those therapists were they were so alone in their shame and guilt that they didn't talk to anybody about it. So that's one about, it's not dependency per se, but it's just the shame that people have, not only about having sexual relationships, and as I said, many therapists don't have that, but people are locked away by shame. Shame is a soul killer. So, and even just feeling dependent, people can be very experienced as very painful. Many people have called me, for instance, I don't know, maybe 5 or 6, not that many, but with difficulties struggling to free themselves from their therapist because they have such a strong erotic transference. And I was helpful in none of them. I mean, maybe talking to them a little bit, but it just, they couldn't break free of that dependence, and it's a very strong one. And it may be due to therapists maybe enjoying it and not enabling the patient to express all their feelings, because they have a countertransference resistance to hearing. Countertransference resistance is you resist something and you're not conscious about it, so you have a difficulty becoming conscious, for instance, of your not wanting to hear criticisms of your work, or not wanting to hear maybe their feelings about having such a transference to you. So that's a big problem in therapy, countertransference resistance to, and it hinges on therapists wanting to be liked, wanting to be admired, always wanting to be, kind of on a pedestal. And if they don't work out that, then they're going to have a difficult time doing therapy in general. So countertransference, as we say again, that's all the feelings that a therapist has towards a patient. Just can wrap them up all in all of them, all the feelings. Joy, love, hate. They need to be conscious of those. But dependency could be welcomed or discouraged by a therapist, depending upon their feelings about the patient being dependent upon them. And they might not be comfortable with dependency. Now, we did a podcast talk on Jane, part 1 and part 2, and there was a quote in there that the therapist needs to welcome the dependency of the patient wanting to be important to that therapist, because it really is something that they didn't have enough of in their life, being able to be dependent. Like in Jane's case, she couldn't be dependent because it was too fearful. She would be overwhelmed and engulfed by her needy, demanding mother. So she couldn't have a easy, early attachment, a secure attachment. Very, very scary for her. And there's a quote in there that says by one of the leading therapists that says that's the raison d'etre of infants in mother relationship, to feel that important to the mother. And that's what a therapist also will encounter in his work or her work with in therapy. I know maybe you don't think about this in terms of what you're thinking about therapy. You want to go and talk about your depression or your work problems. But somehow these things need to come up because they all are related to your work problems, your relationship problems, your troubles with your husband or your wife, dependency. So you may not think that that's going to come up in therapy, and that's not why you're calling. And mostly if you have a little blip, in your life in depression, you had a little breakup, but it's not a big deal. It's not a repetition of other things, then you won't encounter these kind of things. But if you stay in therapy for a while, it will come out. Now, in Jane's case, she became dependent upon me in a good way. I was supportive with her, and I wasn't acting like the mother, being very controlling and critical. I was very accepting, and she became very attached to me in the end, although she was fighting like hell in the beginning because I had so much contempt for me, and that was transference. But she had to let it out and verbalize it, because her mother certainly would not let her say anything to her. She would just pull her hair and say, "What's the matter with you?" That was terrible. So you can check that. I think we talked about Jane too, but again, it's a long, it's the parts on the podcast. It's on part 4 and 5, I think, and also 6. So the raison d'etre, to be. That's a child needs to really feel that that the mother considers the child very important to her existence. And Jane's, the mother couldn't accept that dependency. She couldn't neither love or hate Jane, because all feelings directly expressed or consciously becoming aware of that, they weren't acceptable. But she acted them out by pulling Jane's hair and demanding that she eat all her food on the plate, or else. She knew better than Jane whether her stomach was full. Well, that's crazy. And that reverberated down through her life in terms of her being not such a good mothering person. So therapists sometimes might not let the patient go very easily, because they're in some way dependent upon them to stay for whatever reason, whether it be separation anxiety that they have, or not willing to be able to elicit critical feelings from their patients, so the patient just doesn't want to leave because they haven't expressed all their feelings in therapy, only some of them. And although therapists train very hard to work on these things in training in their own therapy, sometimes it's just very difficult, particularly with eliciting complaints and negative feelings toward the therapy and the therapists. I've had trained people who have worked with me in my groups, and they've admitted that when they terminated treatment with their therapists, they were not able to tell them that they were disappointed in their therapy. So, it happens to the best of us, but it's a very difficult thing to help therapists become comfortable with all their feelings when working with their patients. That's why therapists had to spend so much time in their own therapy, and good training programs too. And sometimes there's a gratification that the therapist has that's acted out. In other words, they're not conscious of the pleasure that they get in the interaction. And there is a lot of pleasure in the interaction. There should be, but they're not conscious of it, and they're not conscious what they're acting out, like being conversational a lot and talking a lot, and sometimes talking about themselves. And that's not a bad thing. I mean, a lot of patients know about a lot about me as I work with them for time, but not in the beginning. But that could be a very difficult thing for a therapist to let go of, to the gratification. And it's not that therapists shouldn't be gratified, but that shouldn't be a primary reason to work with somebody when they may need to pull away, and they may need to separate and talk about things that they're not talking about because it's so gratifying to have this wonderful conversation. And then the therapist gets all caught up in it, and doesn't realize that they are indeed acting out something that perhaps they never got from their caregivers, which is, being paid attention to, being listened to. That's a certain element that's nice in therapists. Alice Miller, though, wrote a problem with wrote a paper. She didn't write a problem. She wrote about the problem, and analysts have it was the tendency that since they weren't paid much attention to, they now the patient listens to their every word, but they're not welcoming any angry feelings from the patient. That's not, they like the admiration, adulation, but they don't elicit the angry feelings. So that's not going to be happening in therapy in the beginning. You're not going to ask well, I often ask people how their sessions are going. How is it working with me? And I like when they offer some objection to what happened in our first session or second session, because, and then I might ask them if they're prior therapy, did they have therapy? And if they said yes, and I'll ask them how it ended. And did you talk about your disappointments with your therapist? Usually it's no. So I might ask them, do you think you could talk about your disappointments working with me? Supposing I make a mistake and I don't know you that well because it's just our beginning sessions, would you be able to tell me you didn't like something that I said or something? And usually they will say yes. Whether they can do that or not is another story. Yeah, that my study that it was on the incidence of erotic countertransference in clinical social work practice. It was a quantitative study, and what I found was that also that people were not trained in erotic countertransference, which means the sexual feelings that the therapist has that he or she is either willing to accept or not as existing in them. So they weren't trained. And I just asked somebody that I've been working with in therapy, who happens to be a therapist, and I said, did you ever explore this in your studies, in learning about your social work or psychotherapy? She said, no, it was never brought up. It's a hot topic. It's a hot topic. So I want to thank you for being here today with Tuesdays with Mark on the YouTube channel Therapy for the Heart, and I hope to continue to be here on Tuesdays. So last week, as I said, I wasn't. So, and by the way, this dependency on the therapist was motivated in part by some comment that someone made on therapy on the YouTube channel about one of the talks. I think it was the first talk, but she wondered about detaching from the therapist, and could I talk about that at some point? So I asked her, well, have you personally brought up this subject with your therapist? So I didn't get an answer. Maybe she did answer me. I'm not sure. I'm interested in that answer, though. Maybe this conversation that we're having here would help her in that difficult question about detaching. But I asked her, well, what is the problem? Maybe she'll write to me and tell me. That could be. Okay, so this YouTube channel, Therapy for the Heart, 41st talk on the dependency between therapist and patient. And I'm going to say goodbye now. And please subscribe to the channel. Press the button where it says like if you like it. Write to me at marksehl@gmail.com. Visit my website at marksehl.com and write to me at marksehl@gmail.com. So again, thanks a lot for being here. Don't forget to subscribe or like the talk. All right, bye bye for now.